The shoulder joint is one of the most intricate and complex joints in the human body, capable of handling immense amounts of internal stress while maintaining its incredible flexibility. The shoulder's design allows it a huge range of motion, which includes forward flexion of 180 degrees, extension of 45 to 60 degrees, external rotation of 90 degrees, internal rotation of 70 to 90 degrees, and abduction to 150 degrees. A testament to the shoulder's endurance can be seen in baseball. A professional baseball pitcher's arm can rotate at rates in excess of 8,500 degrees per second. If that single instant of speed could be maintained, then a pitcher's arm would spin around 24 times in a second. The shoulder joint is commonly misconceived to be a single joint. However, it is actually two. The first, known as the glenohumeral joint, is a ball and socket synovial joint that is diarthrotic, meaning freely movable. This joint is formed by the articulation of the curved head of the humerus and the shallow bowl-like depression of the scapula, called the glenoid cavity or glenoid fossa. Both the head of the humerus and glenoid cavity of the scapula are covered by hyaline or articular cartilage. The head of the humerus is roughly 3 to 4 times larger than the articular surface of the glenoid fossa. Though the glenoid fossa is rather shallow, it is made deeper by a ring of cartilage attached to the circumference of the cavity, called the glenoid labrum. The notable size difference between articulating surfaces grants both humans and other primates a distinct advantage, an increased range of shoulder motion. Unfortunately, almost every advantage comes at a cost. In this case, a compromise in the stability of the shoulder. The second joint is the acromioclavicular joint, classified as a plane or gliding synovial joint, and is diarthrotic in function. As the name suggests, the acromioclavicular joint is formed by a junction of the acromion of the scapula and the lateral acromial end of the clavicle. The integration of this joint grants the shoulder some increased flexibility that wouldn't be possible with only the glenohumeral joint. These two joints work in unison to grant the upper appendage the ability to circumduct in a large circle as well as rotate around its axis at the shoulder. Since the shoulder is highly mobile and frequently used, it needs substantial protection from damaging friction. All joints, with the exception of fibrous joints, accomplish this through a coating of hyaline or fibrocartilage on the articular aspects of each bone involved. The shoulder joint is classified as synovial. Therefore, it has the same protection of a cartilaginous joint as well as the addition of a joint capsule. In the case of the shoulder, this capsule is known as the articular capsule of the humerus. The articular capsule encompasses the entire glenohumeral joint, attaching to the anatomical neck of the humerus as well as beyond the glenoidal labrum. Because this capsule is relatively loose, it can allow the shoulder to dislocate rather easily. All joint capsules consist of two parts, an outer fibrous membrane that may contain ligaments, and an inner synovial membrane called the synovium. This membrane secretes a thick, lubricating, and shock-absorbing liquid called synovial fluid. Another characteristic of synovial joints is the presence of bursa, or bursae plural. Bursae are small fluid-filled sacs which aid in joint mobility while reducing friction between moving parts of the joint. Bursae are typically located where muscles or tendons pass over bony prominences in a joint. The shoulder has 6 bursae, 4 of which can be seen here in this diagram. Since the shoulder has such great freedom of movement, the joint needs significant reinforcing to prevent dislocation. The first line of reinforcements are the glenohumeral ligaments. The shoulder contains 8 ligaments, 6 of them acting directly on the shoulder socket, and the remaining 2 stabilize the joint between the scapula and clavicle. Starting inferiorly, the first of these ligaments is the glenohumeral ligament, which is divided into 3 bands: inferior, middle, and superior. These 3 bands reinforce the anterior articular joint capsule as well as play different roles in the stability of the head of the humerus, contingent upon various arm positions and degree of rotation. The transverse humeral ligament bridges between the greater and lesser tubercles of the humerus. This connection between tubercles formed by the transverse humeral ligament converts the intertubercular sulcus into a canal, allowing the tendon of the long head of biceps brachii to pass through and attach on the supraglenoid tubercle of the scapula. When following the pathway of the tendon of the long head of biceps brachii, it can be seen that it spans the entire shoulder cavity and creates a suppressive downward force on the humeral head, preventing potential upward migration. The coracohumeral ligament spans from the root of the coracoid process of the scapula to the greater tubercle of the humerus, ultimately strengthening the superior aspect of the joint capsule. The final ligament acting directly on the shoulder joint is the coracoacromial ligament, which connects the acromion and coracoid processes of the scapula. The coracoacromial ligament is considered an accessory ligament, meaning a ligament that supports another ligament. The coracoacromial ligament protects the superior aspect of this joint by forming a fornix, or arch, essentially restricting movement of the humerus in the glenoid cavity to 90 degrees in abduction. The remaining two ligaments serve to hold the clavicle and scapula together and have no direct influence on stabilization of the humerus. The first of these two ligaments is the acromioclavicular ligament, a four-sided or quadrilateral band which extends from the superior aspect of the lateral end of the clavicle to the adjacent portion of the superior surface of the acromion. This ligament's position adds horizontal stability to the acromioclavicular joint. The second is the strongest stabilizer of the acromioclavicular joint, called the coracoclavicular ligament, which connects the clavicle to the coracoid process of the scapula. These joints have sparse, weak, and relatively small ligaments. Thus, their stability is almost entirely dependent on surrounding muscles. The most important are the rotator cuff muscles, consisting of the infraspinatus, supraspinatus, teres minor, and subscapularis. Each of these muscles originates on the scapula and inserts on the tubercles of the humerus. Together, these muscles and their tendons form a cuff around the humerus. There are several other muscles outside of the rotator cuff that help to stabilize the shoulder. First is the long head of biceps brachii, which adds stability to the head of humerus during abduction. Second is the deltoid, which originates on both the spine of scapula and the anterolateral aspect of the clavicle. Muscle fibers of the deltoid encompass the entirety of the shoulder socket, making it the most sturdy muscle in the stabilization system. Lastly, the teres major, latissimus dorsi, and pectoralis major create opposing tension with the muscles of the rotator cuff, resulting in stabilization of the humerus in the glenoid cavity. Although these joints are held together by an extensive network of muscles and ligaments, the shoulder joint is still highly susceptible to damage. Sudden jerks of the arm, especially in children before strong muscles have fully developed, can lead to dislocations. There are degrees of joint dislocation called subluxation. A subluxation occurs when the two articular surfaces of a joint have lost their usual contact. An example would be 50% subluxation, which indicates that the articular surfaces have lost 50% of their contact, resulting in a partial dislocation. This is different than a dislocation, as a dislocation occurs when there is 100% subluxation and articular surfaces have completely lost contact with each other. In this case, it would be when the head of the humerus is entirely separated from the glenoid cavity. A more common shoulder injury seen in adults stems from acute or chronic erosion in the glenohumeral joint, leading to painful tearing of the glenoid labrum or of the tendons in the rotator cuff. Both of these conditions are extremely painful and may require surgery to reattach or remove any tissue that was torn. It is truly fascinating that the human body could have evolved such intricate and mobile joints. This video was prepared as part of the course requirements for Human Anatomy at Saddleback College.